The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody. I want to welcome you to the webinar this morning. My name is Joe. I'm the training manager with PrognoCIS. We're going to go ahead and get started. Just to point out to you here, if you're not familiar with the webinar format, you have entered in auto mute mode. However, at the end, there will be time for Q&A. So if you do have any questions, I'll be able to unmute you. Just click that little hand icon on the control panel when I ask. All right, to make sure that you've joined the correct session, what we're going to talk about this morning is with regards to the new Denali upgrade. Specifically, the first part is going to be your setup for the Meaningful Use and Quality Payment Program, because that is one of the key pieces of the upgrade. But then we're also going to look at the general features of the upgrade, which are required for certification, but not necessarily specific for meaningful use or quality payment. So this is kind of a combined program. We've also got a couple of other sessions going on right now. One of those is intended for the summary of the quality payment program without PrognoCIS involvement, where we're basically just summarizing all of the requirements from the CMS perspective, helping you understand how they calculate your score and the measures that you have to choose. That one's been going on now for a little over a month and will actually be ending soon. And then we're going to be picking up with a couple of other feature-related webinars that focus on specifically the measures of compliance and how those are implemented, so you know exactly how the data is getting captured and reported. But this one, again, is kind of a hybrid where we're going to just summarize the requirement from CMS, get into the settings, and then also the general upgrade features. So first of all, just a reiteration of the other session, condensed down here to just a couple of minutes. The quality payment program is applicable to providers who qualify on the Medicare side of things. Meaningful use is for providers who qualify on the Medicaid side of things. Quality payment is the umbrella under MACRA for Medicare providers that is replacing your traditional fee-for-service Medicare with two new performance-driven payment tracks. One of those is called MIPS, or the Merit-Based Incentive Payment System. The other is Advanced APM, or Alternative Payment Model. The focus in 2017 is the MIPS side, and that is what we're going to be concentrating on. If you have qualified previously for meaningful use as a Medicaid provider, that continues as is through the year 2021. But if you were attesting to meaningful use as a Medicare provider, that ended in 2016, so now you will shift over to the quality payment program. For the MIPS side of the quality payment program, on the CMS website, they do have this participation lookup wizard. So based on your personal NPI number, you can find out at what level CMS is expecting you to participate, whether you're eligible as an individual, eligible as a group. You may be eligible both as an individual and as a group. You may not be eligible at all. This is all based on your Medicare volume, both the dollar amount that you bill for allowed Medicare charges, as well as the number of Medicare patients that you treat. So it is important that you go in and verify if you're eligible or not. And then within the MIPS program, what they have done with this program is created 4 different categories. Now for 2017, we're only worried about 3 of them. The cost category is not applicable this year. So the MIPS program, as far as what you need to capture inside PrognoCIS and then ultimately attest and report the data for, is broken into 3 categories: quality, improvement activities, and advancing care information. Those are the 3 categories that you need to set up, which is what we're going to look at here first. Now again, I just went through that very quickly. There's actually an hour-long session that deals with all of that in detail. There is a recorded version on the Resource Center of a previous live webinar, as well as the PowerPoint version. And then at the end of this PowerPoint today, we have included as an appendix the scoring piece of that. in case that is something that you would like more information on. But getting into the actual upgrade itself now, we're going to first of all look at the settings master. For each provider in your practice, whether you're going for the quality payment program or meaningful use, each provider that is reporting needs to be defined under this settings configuration master. Formerly, it was simply called MU settings because meaningful use was the only program out there, but now we've renamed it to MU/QPP. It has also been redesigned in addition to being renamed. So it's using our new accordion design interface. And as you see here with the three bubbles, it's kind of in three sections. We've got our clinic level, which is going to be applicable to all providers in your practice, regardless of if it's quality payment or meaningful use. Then we have the provider setting, which is specific to each individual provider. And that provider will identify which program or programs, as well as which exclusions. And then the bottom part, for each provider that is selected, you will choose the applicable measures for the program and the category. So once you get the upgrade, this is definitely the first thing that needs to take place. So first of all, under the clinic setup, and again, this would be applicable to all providers in your practice, regardless of the program that you're reporting under. In the upper left, we have your encounter type designations. Now, at this point in the QPP-MU master, this is display only, so that you can visually see that you have defined your encounter types. The encounter type designation is actually done under the encounter type master. But this is a reminder that for meaningful use, as well as for the MIPS program, the ACI category specifically, your encounter types do need to have a designation as to whether or not they qualify as being billed as an office visit, because certain measures applicable only in that scenario. Similarly, encounters that are seen by an eligible provider, meaning the reporting provider, as opposed to maybe a nurse visit or a blood draw where it is not subject to meaningful use or quality payment program, and then any encounters that across the board are exempt. And that again would be applicable to all providers. That middle section then is with regards to the public health reporting measures, also part of meaningful use and quality payment MIPS, the ACI category. Now there's three types of public health reporting right now: the immunization, syndromic surveillance, and the National Ambulatory Medical Care Survey. And then the third column would be vital signs and smoking history questions that are applicable for reporting on the CCD document. Those aren't necessarily required anymore as a core objective as they formerly were, but the fields are still mapped to the health summary. And then that number 4 bubble, there's an additional setup icon. This you probably will not need to go into, quite honestly, unless you have preferences that you want to modify, or if you need something enabled that is not yet enabled. So there at the top, you have the different dashboards and whether or not meaningful use is even turned on in your practice. For instance, that middle icon there at the top, enable MUQPP global dashboard, versus the third option, show encounter level dashboard. Some of you do not like the pop-up on your encounter close where you have the green thumb up or the red thumb down. You can turn that off if you don't want to. By default, it will be turned on. And then in the interface detail section, you can see which interfaces have already been turned on at your practice, which ones you've requested, whether they're turned on yet or not, and if there's something that you need enabled, you can send an email here directly to our interface team to get that process begun. The second section is your provider setup. Now, this is going to be for each individual provider who is reporting under one of these programs. So this would be your physicians, your nurse practitioners, your midwives, your physician assistants, any professional in your office that qualifies for one of these programs and will be reporting and submitting data. It's applicable that for each provider, the reporting year be defined. Now, right now, of course, 2017 will be your only option, so it will automatically default. But you need to remind yourself then that starting next year, in case your program changes or your measures change, you will need to come in here and define this again for the new year. And the reason for that is the definitions of measures can change from one year to the next. And you want to make sure that the appropriate reports are being gathered and that the appropriate definitions of the measures are what we're looking at for you. So for each provider and reporting year, you're going to define the quality payment program or meaningful use or both or neither. Now the default is neither. So if you're not going to participate, then of course you don't need to worry about this. But if you are participating under the quality payment program, meaning the Medicare side of qualification, you're going to select either MIPS or APM. Most of you, if not all of you, will be MIPS. The APM, as we mentioned in our earlier set on the program level session that we're teaching, is only open to a few select. You had to register with CMS and be approved. And out of our PrognoCIS family, there were only 2 or 3 that did that. So almost all of you are going to be selecting MIPS here. If you're still attesting under meaningful use under the Medicare umbrella of CMS, if you want to stick with modified stage 2, you will already be set up for that when it transfers over during conversion with this upgrade, because previously modified stage 2 was the only program that was out there. So if you were already set up in 2016, you're going to still be set up in 2017. So that would be the only scenario where you don't need to come in here and make any changes. However, with the new certified version, you are able to go ahead and move over to stage 3 if you so desire. A difference from previous years where you had to choose one or the other under MU, you can do both now. If you qualify both as a Medicare provider and a Medicaid provider, and you are still attesting under meaningful use because you haven't completed the full 6 years, you can now also participate under MIPS while continuing under MU. And that means you could end up getting 2 incentive bonuses. Now, those functional exclusions are applicable for meaningful use as well as the ACI category under quality payment MIPS. So as an individual provider, regardless of the other providers in your practice, if you do not do electronically prescribing of controlled substances, if you personally don't do immunizations, if you're personally not required to support or report syndromic surveillance or any specialized data, then you're able to take those exclusions. So you'll do that setup and save it. That way, for each provider, you've identified the program year and what program and exclusions are applicable for that year. And then that brings us to all the different measures down below. And this view that you're seeing is when up above you've not chosen any provider yet. So there's no program specified, so none of the measures will be populated. And you see there in each of the accordion layers, this program is not applicable. Once you have defined the program up above, these accordion layers will be populated accordingly. And then these can be collapsed or expanded by clicking in the colored banner area, that little triangle icon. So just going down the 4 categories overall, the quality measures, that pink layer, is applicable actually to everybody. So whether you're doing meaningful use or quality payment, you will be choosing quality measures. So that accordion layer will automatically be expanded and populated once you have selected a provider up in the middle section and assigned a program. Now, ACI measures and improvement activities will only be applicable for those of you who have chosen quality payment program MIPS. So if you chose MU only, then these will continue to say the program is not applicable, as you see here next to the number 2 and the number 3. But if you've chosen QPP MIPS, those also will be expanded and populated with the measures. Meaningful use then, the 4th category there in green, will be applicable to meaningful use only, regardless of if you are also doing QPP or MU only, and it will be populated according to the stage you've chosen, either modified stage 2 or stage 3. So now we're going to look at how you choose the individual measures within each of those bands. So first of all, with the quality measure tab, the first option at the top of each of these layers, and this is going to be applicable to all 4 of them, when you expand that tier in the accordion, there's a reporting period, and you have a from date, an up to date, and a submission date. These are not mandatory right now during setup. You will worry about this when it comes time to do your attestation after January, when it's time to submit your data. That's when the reporting period will be chosen, whether it was a week, 90 days, the whole year, and then the day you actually submit your data or do your attestation. So they are going to be mandatory, so to speak, but not to do your setup. So for right now, you can ignore that. Then we have a tier under quality only. You will see these 2 tabs, claim-based or EHR-based. This is based on the way you're going to submit your quality data under the quality payment program for MIPS. Now this quality measure tab is a little ambiguous in that it is applicable regardless of if you're QPP, meaningful use, or both. The difference here in the 2 tabs that you see next to my number 2, claim-based is only applicable to quality payment program MIPS, period. EHR-based is available to anybody, including QPP MIPS. So for QPP MIPS only, you have a choice, claim-based or EHR-based, and you must choose at least 6 measures from either one of those tabs, but not both tabs. Now, if you are choosing the APM model instead of MIPS or meaningful use, either stage 2 or stage 3, your only choice for quality is EHR-based. In choosing any of these measures, regardless of claim-based or EHR-based, that little blue area gives you options to search and filter. These parameters will vary from one layer to the other also as we go down through the 4 accordion layers. Here under quality, you can filter by the type because each measure under quality claim-based and quality EHR-based is given a type by CMS. In my example here outlined in blue, I'm showing you process measures. There's also functional, structure, efficiency, outcome. So there's a variety of types. That is a filter choice because the requirement of choosing at least 6 measures also requires that one of those be identified as an outcome type measure. So in helping you decipher through all of these, you could filter by outcome type, and it would be easier for you to decide what measures you want to go for. Now, you do not need to use these filters. You can simply scroll through, and every measure available is going to be applicable. You can just choose it that way by using your scroll bar. But these search options are there if you want to use them. And then in the measure detail section is where you're going to see the measure number, the measure name, the type, the high priority status, what specialties it's applicable for, and then in the far right, there is an info icon that allows you to read the definition and requirements of the measure. So as you choose a measure that you want, you're going to simply click that checkbox in the far left margin, as you see next to my number 1. And then that will put a check mark in that box. Once you've chosen at least 6, you can click the Save button in the lower right to save those 6. Now you can choose more than 6. And as we discussed in our other session, when it comes to your scoring, you can get bonus points for that. But if you just want the bare minimum points to pass and get some sort of a positive adjustment, you need to submit at least 6. And those 6, again, must be either all claim-based or all EHR-based. That's in the context of QPP MIPS. One of those must be identified as an outcome measure or a high priority equal yes, depending on if your specialty has an outcome measure. If not, and many specialties don't, then you can choose one that is applicable to your specialty that says high priority yes. And then to verify all of the definitions and requirements, you can click the little info button there on the far right. And here's a couple of different examples to compare a claim-based versus an EHR-based. Because that accordion design we just showed you is applicable both claim-based and EHR-based. The measure lists, however, are different. The way you submit your data is different. because claim-based data, CMS is going to process off of your claims. So as your claims are coming in for Medicare and there's a quality data code present on that claim, that triggers CMS, okay, this is their quality report. And they'll plug in the measure and give you your evaluation. So that's the example here on our left, the bigger background. Because when you open it up, it's going to give you the code requirements for your denominator, the gender, the age, the diagnosis, the CBT HCPC, because all of that is on your claim. And then the numerator criteria, which is actually partially hidden by my other pop-up here, that's where your quality data codes are. Those quality data codes go on the claim so that CMS knows that's a claim-based quality measure for you. Now, the lower right example is an EHR-based measure. Notice in both of these, I am showing you the hemoglobin A1C pore control. So there is similarities between the two, but the differences of how you report the data are what matters. On an EHR base, it doesn't care about your claim code because it's not looking at the claim level, it's only looking at your clinical documentation. So it's telling you what needs to be done. On the EHR based, for a poor control of an A1C, it just says that you need to order an antibiotic and give them a strep test. Whereas on the claim base, it's looking at the value of the A1C, and based on that, it wants you to put a certain code. So this is a good example of understanding the measures you choose, but realizing that you have to decide on the method of submission, because that is what will determine how you document the data. So that would be your quality measure category. Choose at least 6 of them. Make sure one of them is at least an outcome or high priority for your specialty. All 6 needs to be either claim-based or EHR-based, but not both. For ACI measures, and again, this we're talking under the QPP MIP still. ACI measures, again, your reporting period we'll worry about when you do your reporting in January. Your search filter by are optional, but this time the choices are different because for ACI measures, they do not have a measure type like outcome, efficiency, structure. That was only for quality measures. So here, we're more concerned with, is this ACI measure required for the base score? Because within the ACI category, there's 3 subcategories. The base subcategory is mandatory for everybody reporting ACI. So you might want to filter just those to get familiar and realize what your data capturing responsibilities are. But then there's also a performance subcategory and bonus subcategory, which helps you get additional points. So you can filter at that level, or you can filter by the score weight. Selecting them then is going to be the same as under quality. As you're reading through, you'll click the check mark. The significance here, however, if you notice my number 1, all of the measures that are considered base will actually be pre-selected and grayed out. You will not be able to deselect it because they're mandatory. But the other measures, the performance and bonus measures, are optional. So those are the ones you'll be able to choose if you want additional points. And if you notice the number 2 bullet, there is this one measure called CEHRT used. This is only applicable in conjunction with our next category that we're going to look at, improvement activities, in conjunction with getting a bonus. So there's a little bit of overlap here because under ACI, you have base performance bonus. Some of the improvement activities count as bonus ACI, even though improvement activities themselves is a separate category. So in this scenario, if you are going to go for your improvement activities that require EHR, and there's only 18 of those with that specific designation, you must also choose this middle measure here, identified by the number 2, in order to get your bonus. And that brings us to that third category of improvement activities. The report period and search filter by, again, are optional. This time, the filter choices are different again, because with improvement activities, there is a weight associated, and that weight is what determines the number of points you get. The requirement in submitting data for improvement activities is a number of points. So based on the weightage or the number of points, you will determine how many activities you need to actually submit. They're either going to be medium or high. And then you also have 18 of these, as I mentioned up above, that qualify as an ACI bonus. Those are the ones indicated here by my 3B, where in that column called Related ACI Measures, there's text. That text is letting you know that there's an EHR component for that activity, because otherwise your improvement activities themselves don't require data capture in EHR. Only the 18 that qualify as bonus do. So as you're choosing your activities to get your 40 points, you can also then decide, based on the ones you've chosen, if it also qualifies as an ACI bonus. Not only would you then get your improvement activity points, but also if you go above and choose that bonus measure I showed you, you will also get bonus points. And now viewing these activities, similar to what we saw under quality, you get a little pop-up. Now here the differences are subtle. You have to actually read them, because the one on the left-hand side is an improvement activity that is not does not qualify as bonus. So you don't need to store any data in EHR, but you get your improvement activity point. The one in the lower right is a bonus improvement activity that qualifies for ACI bonus if you do something in EHR. Now the subtlety is in the way it's worded, because the one on the left simply says that you have to do an annual registration in your state level drug monitoring program. So that is a requirement for you as a provider with your state. You register with their drug monitoring program. You get to declare compliance on that activity. Doesn't mean anything is done in EHR. So there's no bonus. The one on the right-hand side, however, says in order to get the improvement activity points, you need to implement a policy amongst your staff whereby you are regularly updating individual patient, at-risk patients' care plans. But because it's identified as a bonus, you need to do that inside EHR. So the importance of reading these things and making your choices are there based on whether or not you want those additional bonus points. Now that final tier in the accordion is meaningful use. This would be applicable to providers who also have just done everything above because they're MIPS, but now they're also doing meaningful use because they're both eligible as Medicare and Medicaid. If they're not doing MIPS, then what we just went through is not applicable. They only come here to MU. And again, if during conversion you already attested for MU, mod stage 2, this will be predefined accordingly with modified stage 2 measures pre-selected. But if you change it to stage 3, then you can choose the stage 3 measures. So that is the setup. Once you've got the upgrade, the most important thing so that you're sure that all your data is getting captured so that come January you can do all the applicable reporting. Now, in addition to that, part of the upgrade included new reports. We will have new dashboards, but unfortunately those are not available just yet. They're coming. But you do have the reports available in the meantime if you want to capture data as you go and watch yourself. The reports obviously aren't really mandatory until the end when it's time to submit your data, but a lot of you like to keep track as you go to see how well you're doing. So this is just to let you know that within the change, we've added all of these MIPS reports. Previously, those weren't there. And then for meaningful use, we've brought over the modified stage 2, but also created stage 3. And so all the reports are categorized now by the year and the program. Because these will all be archived, of course, moving forward, you'll be able to go back in time and generate the appropriate report based on the year. And then for the MIPS quality, this option used to be called PQRS report because your claim-based quality used to be called PQRS. PQRS no longer exists on its own. It has been turned into the quality claim-based category under MIPS. And these reports also have additional filtering available to you now, and you can generate them for more than one doctor at a time, instead of having to generate a separate report for each provider. And then for the what used to be NQF, or your quality measures, there are detail reports available, the QRDA1. That is where each measure that you're choosing to report under that quality, whether it's the claim-based or EHR-based, this gives you all the patient-level detail for each of those measures. So if you're passing or failing, especially the failing, you can see what's wrong and what's missing, and you have time to go in there and fix it before you actually submit your data. And then the QRDA3 is the report equivalent of the dashboard, where you just get the high-level bottom line for each measure. So those have just been reclassified again because they're part of quality as well as meaningful use as well as APM. And then speaking of that QRDA1, if you are new to PrognoCIS and just converted, and you had already started at an existing EMR before you came to us, you can extract your QRDA1 data from them, import it to PrognoCIS via this new import screen and user permission. And then when it comes time to submit data in January, you'll have both what you did in PrognoCIS as well as what you did before you came to PrognoCIS. And again, for the quality, the PQRS equivalent that we used to have, the screen is still here. We've just renamed it to quality measures. And this is quality claim-based again. Used to be PQRS. Now it is the quality claim-based category under MIPS. And we've just modified the nomenclature to match. So instead of G code, that column is now called QDC. That quality data code is what needs to go on the claim. And if you're not doing the claim-based, of course, you don't need to worry about this. And then for the EHR-based, as well as claim-based, you can use this little button. It used to be labeled NQF because previously these measures were identified as an NQF measure. Now they're more labeled globally as ECQM for electronic clinical quality measure. And this is where you can see at a patient level, for that encounter rather, not just that patient, but for that encounter, is it failing or passing? And you can click on those hyperlinks and get the detail as to what's wrong. Maybe you've got an invalid diagnosis or an invalid CPT code or something. And then that far right column that says overall lets you know how you as a provider are doing for that measure overall. So the denominator numerator is specific to your current encounter. The overall percentage is that measure per doctor performance. So you kind of two parts of that dashboard. So that is specifically the MU QPP setup portion of the upgrade. Now, again, there is going to be another webinar coming up that deals with the actual data capture, what you do for those measures, where, what screen, and so on. But that setup is the most important. Now we're going to look at the general features included in this upgrade. Some of these are because of certification purposes. So even though they may not be a mandatory measure, in order to get certified for the new measures, these functions were required. So under the patient register, first of all, we now have a name suffix. It's a 10-digit free entry field where you can store the suffix. And if you're going to use that and you want it included in your system wherever you see the patient name or wherever you print the patient name, there are tags accordingly so that you can modify those properties or modify the template to include this S value with the tag, and then the system would show the suffix along with the name. Also at patient register level is a new gender choice of unknown. So in addition to male, female, you can now say unknown. And then that could correspond with the new sexual orientation, gender identity, where there are additional choices for transgender, other, if the patient has a different type of identity here, You'll notice that in these pick list choices, there are codes. Those are SNOMED codes for each of those values. So predefined values are applicable, or you could choose other and then manually type in what the patient's preferences is, or self-identity. And if you're going to use that feature, we have a lot of new tags for those as well, because a lot of your templates can be gender driven. Or when you're using your report sentences for your progress note, you want it to come out with pronouns or he, she, his, her, so that the flow of the verbiage. So there's some new tags that include unknown now. So it'll be either male, female, unknown. However, in the case where it's his, her, or he, his, it's still going to be the masculine pronoun if you say unknown. There isn't any transgender equivalent right now in the pronoun world. Another change for the preferred is at the preferred language level. It has now been turned into an interactive hyperlink instead of just a master file search. It now accommodates multiple languages per patient, one of which can be designated as preferred. You can have up to 10 languages per patient. Along with each of those, you can indicate the patient's level of expressing it or receiving it, as well as their proficiency level, if you care to have that level of detail on their chart. So whether they express it or receive it, you can indicate whether it's the sign language, the non-hearing equivalent of the language, whether they can speak or understand it, meaning hear it and speak it, or whether it's just writing and reading that language. The tag for language has been modified then to include which value you want included. If you use the copy feature under patient register, language will automatically copy over unless you indicate not to, such as in your sibling management. You get an option to deselect if you don't want it to copy. But if you are copying the patient into a duplicate registration, it is also going to copy. Ethnic group now also accommodates multiple choice, so you can have up to 5 ethnic groups if the patient prefers to identify with more than one. All of those choices, again, are optional. They're not mandatory, but they are required for certification. So therefore, you will get a validation alert if you choose not to enter those values. This is not an error, so you can say, no, I don't want to add them. When it says, do you want to add them now, say no, and it'll still save everything else you entered up to that point. But this is a reminder, it's recommended you enter that data. Now, in your existing version, or if you haven't already got the upgrade, your older version, the verbiage of this said, meaningful use required. That is no longer the case because it is no longer mandatory. So the verbiage now just says recommended details. Also kind of related to the patient register, but it's coming out of the settings master for encounter types. You can now create or designate a custom text where the patient gets, if you're using text reminders for your appointments. So each encounter type now may be set up to either use the system default, a custom, or be excluded altogether, so you're not sending a text message at all. The next new feature included in this upgrade is the Implantable Device Manager. Now, implantable devices could include pacemakers, breast implants, stents, prosthetic limbs, basically any device that is federally regulated. This can be accessed from the patient's encounter, either on their table of content menu there on the left. You can have the option implanted device, or as a square on the face sheet. There's also a new heart icon under patient register because this is patient level data. If you're going to use it, the way it operates is based on a web interface to third-party databases. These federal databases, there's 2 of them there identified at the bottom. The Global Unique Device Identification Database, or QDID, which is basically the federal repository for all of these devices, or the Unified Medical Language System, which has the SNOMED codes for these different devices. It's based off of the device UDI, or Unique Device Identifier. So if you notice there next to my number 2, it says enter the UDI, or device identifier, and then the button is called Get Details. So you'll have to get that number from your patient, unless you're the one actually implanting it, and then of course you will know the number because it's on the device you're about to put in the patient. But notice that the number is very long, and it has parentheses, etc., not just a number. So it's not just like 10 digits or something. It's a very long number. So breaking it out for you just to understand, if you're going to use this feature, you have two choices. You can either use the entire number or just the first part of it. So this overall entire string that you enter here is called the Unique Device Identifier. But that is composed of two different pieces. The first part is the device identifier. The second part is the production identifier. You can enter either the entire number or only the first part. Now, if you enter only the first part, you're not going to get all of the details from the federal database. You will only get part of it. Now, in case the number is confusing, or you ask your patient, well, I need the number off of your pacemaker, and they see a different string of text. Like if you notice here in my gray box, I'm dissecting this number now, and I've got some digits showing in turquoise instead of black. Those include a parentheses, but then there's a unique number. Underneath, I have defined what each of those segments represent, because this long number, the entire UDI, has all these different segments in it, and each segment of data is preceded by a delimiter. Now, this delimiter is what the computer uses to parse out the data and bring it into PrognoCIS. So just to give you a translation of that, you see here that behind the 01 is the device identifier. Behind the 11 is the manufacture date, then the expiration date, then the lot number, then the serial number. So if you are going to keep track of all these devices, you probably want all of those details. So if you ask the patient, well, what is your device number? And he just starts saying it's 0871764, that's not going to be good enough. You're going to need to have, is it a parentheses 01, a parentheses 11, or instead of a parentheses, is it a plus sign? Because what I'm showing you in blue could have been a plus sign instead of a parentheses and a number, or it could have been an equal sign or a slash. It depends on which agency issued this ID number. The FDA has accredited 3 different agencies with being able to define these devices. Each agency uses a different delimiter when they define their number, as I've got listed there in that middle bullet point. So my example is simply using the parentheses and a number because this device was issued by GS1. But had I used a device issued by HIBCC, then my example would have a plus sign in blue instead of a number inside parentheses. So that may be a lot of hogwash to you, but in case you are interested in using this feature, it's important to know that you do need to use the entire number, including those characters, so that when we bring it into PrognoCIS, we parse off the data for you. And then in addition to that, you have these data entry fields where you can keep track of when it was implanted, where it was implanted, specifically, anatomically, what was the site of the implant. Instead of just saying coronary stent heart, you can say anterior, posterior, or whatever the detail is that you want. You also have a status that you can manage. Maybe it's something that expires and you need to change it out, or it becomes defective, so you need to change it out, or whatever. So you do have a complete management here where you can just bring it in informationally from that federal database and or then add these additional details to it. So then on a completed screen, as you see here in the background, that middle section is what was fetched from the federal database when you entered the number and said get details. So it brought in the agency, the lot number, the serial number, the manufacture date, all of that good stuff. Now at the top you see an example where a patient has more than one device. And in parentheses, you see the status as well as the expiration date. So it's easy to identify and manage at a patient level. And if you're going to use the feature and you need it included in your progress notes or any of your other output, we have all of these new tags generated that you can modify on your template. Now, the next big piece of the upgrade is medication prescription level, specifically e-prescription changes. So that's what we're going to look at first. For e-prescriptions at the encounter level, you may now cancel it electronically or modify it electronically. This is comprised of 3 different new SureScript messages that the provider will receive in his or her inbox within PrognoCIS from the pharmacy. All of this activity is recorded at the encounter level as well as current medication history. Now, these 3 message types are change request, and there's 3 types of those that the pharmacy can send back to the provider. So the workflow is the provider sends an e-prescription to a pharmacy. The pharmacy now wants you to change it before they dispense it. And there's 3 types of those. There's a generic substitution, a therapeutic interchange, or a prior authorization. The second change is the ability for you as a provider to electronically cancel an ERX. Maybe you sent an e-prescription at 9 o'clock this morning. Now you've got lab results back, or you've rethought it, or you realize you had confused 2 patients and you sent the wrong drug, or you sent it to the wrong prescription, or the wrong pharmacy rather, for the wrong patient. So you want to cancel it. So now you can do that as well. And then the pharmacy can respond either asking you to clarify and confirm or deny it. Maybe they already filled it, so they're denying your request to cancel it. And then the third type are just notifications that the pharmacy's letting you know how they filled the prescription. Did they dispense it or not? Now, in order to use these features, it does have to be set up by Bizmatic staff with SureScript. So it's nothing you can set up for yourself. But the way the workflow is that once it's turned on, you will receive these message types in your inbox. So we're going to look at each of these now and what the workflow is, because they have different workflows based on if you're approving or denying and based on what the pharmacy is suggesting or requesting. So an example here of the different change messages in your inbox, you'll see it's called change request, but then there's a suffix. Part of it is cut off, of course, because of your screen size, but if you hover your mouse over, then that tooltip tells you the full description, whether it's a generic substitution, a therapeutic interchange, or a prior authorization request. So we're going to look at how you approve or deny and what happens to your encounter when you do that. So first of all, we're looking at a generic substitution change request. So in this example, you have sent an e-prescription to the pharmacy for Zestril, 20 milligram tablet. I don't have it outlined, but it's what you see there on the left-hand side, medication prescribed. Now, the pharmacist has decided, I don't want to give you Zestril. I'm going to ask the doctor to change it to lisinopril, the generic equivalent. So he's going to send this message to you asking you to change it. On the right-hand side there, outlined in blue, you see 1A. I've gone ahead and decided that it's okay to resubstitute it for lisinopril. So it's highlighted in green because I've selected it. 1B, then, I have the option of modifying the details. Maybe I don't care that it's a lisinopril 20 milligram dispense quantity 30. Maybe I want to change it. So I can click the edit button before I send it back to the pharmacy and say, yeah, it's okay to go ahead and change it to lisinopril, but I want it to be 10 milligram quantity 60, or whatever the changes are. So you can approve the drug and also change the details, or you could simply have approved it and not gone into the edit button, your choice. But if you do decide to modify the details, you're going to get to see a comparison of what was originally requested versus what you're now substituting or deciding to approve. So it'll strike out what the pharmacist suggested, highlight in yellow what you're replacing it with, and then you'll hit the accept button. So it's very similar in workflow to your refill request that you probably already do. You get a refill request in from the pharmacist, you approve it or deny it. That's the same thing you're doing here. It's just instead of a refill request, they're wanting to change a prescription you sent them earlier for whatever reason they have. And then it's up to you to approve or deny it. Now, if you approve it, the workflow at the encounter level is that original prescription is removed from the original encounter. A new encounter is automatically generated by the system in a closed status. So again, this is imitating your refill request workflow, with the one exception that when it creates this new encounter, it is already closed. It is not going to stay in an open status for you. The only place you will see it is under encounter history. So as you see there in my snapshot under encounter list, you do see a SureScript change request encounter closed status that the system auto-generated because you approved to change the prescription. So again, your original prescription is deleted because it's no longer valid now. You sent it to the pharmacy for Zestril, but now the pharmacy says, I want to change it, and you're approving that change. So your original prescription is deleted. A new encounter is started strictly for the new change. And then that in turn, of course, creates its own progress note also on your document list that indicates what you changed it to. Now, if you deny it instead of approving it, this is going to follow the similar workflow of, again, a refill request that you deny. When you click on the Zoom button, the pharmacist is still suggesting, in this example, the lisinopril. I don't have it highlighted, and it's not selected in lime green because you're denying it this time. So in the lower right, you're choosing a denial reason and then clicking the deny button. And that's going back to the pharmacist saying, no, honor the prescription how I wrote it. I don't want to approve what you're recommending. The workflow here is a little different. There's no reason to delete it and create a new encounter because you're telling the pharmacist, no, leave the prescription how I sent it. So that original prescription stays intact on the original encounter. But what we do in the system, as you notice here circled in turquoise, we overwrite the drug type on that sent prescription. And this doesn't matter if the encounter is open or closed, by the way. Usually that drug type simply says ERX. Well, now we're adding a prefix in there, CHGRES_D, which stands for change request response denied. So that is a record that this is a drug you e-prescribed. The pharmacist wanted to change it, but you denied their request to change it. So it's all done on the same encounter, the same prescription. What it also does, however, is add a new entry to your document list called denied change request. So you have a permanent record of that message as well as the reason you denied it. So if you approve it, it deletes the original prescription, creates a new encounter called change request. If you deny it, it retains the original ERX, but updates the drug type that you denied it and puts a new entry on your document list. Very similar is the therapeutic interchange. The difference here is in the pop-up now. When you click the Zoom icon on your message, if it's a therapeutic interchange instead of just a generic substitution, as you see here outlined in blue, both sides of my screen, the doctor is suggesting one or more alternative medications. That's under my number 2. On the other one up above for generic, there was just the one, so all the details were expanded. Here they're giving you multiple drugs to choose from, so they're showing up in collapsed form. And then on the left, there's a drug use evaluation where the pharmacist can tell you why they want to change it, whatever the therapeutic interchange is. There's a clinical significance. Maybe the drug he's suggesting has less side effects. Or maybe the drug he's suggesting, he knows gives the patient a better benefit or whatever. So whatever the therapeutic reason is, the pharmacist is saying, okay, I got your original prescription, but I want to change it because of one of these reasons. And these are the possible drugs I like better. And again, you get to approve or deny it. So you can scroll down, choose the drug you want to approve. If you want to modify the details again, you can. So that piece is just like we saw for the generic substitution. And you're going to click accept, and it's going to go to SureScript. And then the workflow is the same as we saw for the generic substitution. The original gets deleted, whether it's open or closed. A new encounter is created called change request because you're approving the change request. So again, that workflow is imitating the refill request, similar to what we saw for the generic substitution approval. And then the denial is the same process also. You can decide, no, I don't want to change it. I don't care about the better side effects. I don't care about the better benefit. I wrote the drug I want to give the patient, so give him the way I wrote it. So you're denying it. And then, again, it retains the original, simply overwriting the drug type to change request denied. And that creates a new entry on the document list. So you have the permanent trail. Third type of change request is because the pharmacy wants a prior authorization. Now, this time when you click on Zoom and you open the button, on the lower right where it says medication requested is empty because they're not asking you to change the drug. So this time on the left, underneath the drug you wrote, they're just telling you what the benefits are and asking you to supply a prior authorization. And then you can accept by giving them a prior authorization if you have it, or letting them know you've requested it or it's been denied by the insurance. So you can accept their request for the PA and tell them what that PA is, or give them a status as to, I've called for the PA, but I don't have it yet, but here's my acknowledgement. Go ahead and give them the drug. Now what has happened here on the encounter workflow is similar to the denials up above, whether you accept or deny. Meaning it is not going to create a new encounter for this, whether you approve or deny it. It's simply going to overwrite the prefix on the original prescription, because this time they're not asking you to change the prescription, so that prescription remains valid. They're wanting you to change the details, however, by giving them a prior authorization in order to complete it. So we're retaining the original prescription on the original encounter, whether it's open or closed, but we're inserting the prefix CHGRES for response, and then _A this time because we're approving it. So they're requesting a change that we're approving, but it's not really changing my drug, so it's okay to leave the original drug intact and just update the status there. Excuse me. So that's the change request, new messages. Now the second new piece here would be the cancel request. Now this does require an open encounter only. Everything we just talked about didn't matter if the encounter is open or closed. For cancel requests, there's a new icon on your prescription screen, and if you've already received the upgrade, you've probably noticed. It's ERX, but it has a red X through it to indicate cancel ERX. This only works on an open encounter with a previously transmitted ERX drug. So you're going to be on that open encounter, select that previously sent ERX drug, click the new icon that says cancel. That's going to give you this cancel ERX confirmation, as you see at the bottom, which has a button, cancel ERX. Now I've zoomed in here at the bottom, right above the cancel ERX, there in the lower left, there's actually a request type to either cancel or discontinue. It defaults to cancel, because the assumption here is that if you're going to transmit this, you do want to cancel the whole prescription. So you do not need to worry about changing this request type up front unless you want and you already know. Maybe you've called the pharmacy and are aware, patient went straight from your office, already picked up their prescription, but you had written it for 5 refills. And you decided, oh no, this isn't going to be a good drug long term. You just want to discontinue those refills. So if you know up front, you could go ahead and say discontinue here instead of cancel, or you can just let it default to cancel, cancel ERX, and then the pharmacy is going to send you a message to clarify. Do you want to cancel the whole drug, or do you want to only discontinue refills because I've already partially filled it? So it really matters, or it's determined by if you already know in advance. If you want to go to that extreme and just say discontinue, or just say cancel up front, and in the rare cases where it's already been processed, let the pharmacy send you the confirmation. So now the pharmacy, what has happened on that original drug, because again, you're now on the original encounter, the original drug. We're not creating a new one. We're not deleting that. It's changing the drug type. This time it changes it to CANREQ for cancel request. This means that you clicked that new ERX icon with the red X on it and sent the cancellation request electronically to the pharmacy, and you're waiting for the pharmacy to respond. Now the pharmacy's responding. So you're going to get this cancel response in your message box. So when you request to cancel it, that's a transaction you're doing on the PrognoCIS prescription screen by clicking that icon, and it updates the drug type to let you know you requested them to cancel it. Now you're getting a response back from the pharmacy, whether they approved the cancel or whether they're denying the cancel. In this case, they're approving it, but they need you to give them more detail. So when you click the zoom icon now, you get this message that you see at the bottom, and again, you've got the choice to delete the drug or delete the refills. So when the pharmacy is sending this back to you, they may tell you there in that part at the bottom that's outlined in blue that the originally prescription had 5 refills. So now you can choose to discontinue all 5 or only 4 or only 3 or whatever you want to do. So basically, cancel request is to cancel the prescription or modify the details. So the way they've implemented it here is those change requests is when the pharmacy wants to change it. But now the cancel request is when you're canceling the one you originally wrote, and you just now want to modify it electronically by either canceling only the refills or canceling the entire drug. And when the pharmacy gets it and isn't sure, then they give you this opportunity to again clarify. And if so, how many refills do you want to delete? Now, if they deny your request, maybe you send them a cancel request and the patient already picked it up, so it's too late. Pharmacy's going to let you know, sorry, I'm canceling, I'm denying your request to cancel because there's nothing to cancel, I already filled it. So this doesn't require action by you. So this time in the bottom, those options are grayed out, but you do have the denial reason. So the pharmacist is letting you know why they cannot honor this request to cancel it. In both cases, whether it's denied or approved, it puts a new entry on your document list because, again, this is all tied to the original prescription. We're not changing that original prescription. We're canceling it, whether it's the whole drug or the refill portion only. So the original drug is always retained. The original encounter is all that ever applies. We're just changing that drug type and adding a new entry to the document list. And the drug type this time now is CANRES for cancellation response. So when you originally requested it, it was CANREQ for cancellation request sent to pharmacy. Now it's CANRES, response from the pharmacy, with an either _D for denied it or _A for approved it. Third type of new SureScript change is the fill status when they dispense the drug. So you will get these messages back called RX fill, either dispensed or not dispensed. When you click on the zoom, it opens up the message from the pharmacy. Notice at the very bottom it says user action not required. And it's, as circled in blue here, it's telling you the status. It was filled or it was not filled. And if not filled, it tells you why. Back on the original prescription, whether it's opened or closed, we refresh the drug type. This time it's RX fill _ suffix F means fully, _PF means partially, NF means not. Now, for this to work, there is configuration both by our staff as well as your staff. So the Bizmatics administrative staff has to actually turn it on for each of your SureScript providers. If you're a new client still implementing, you can ask your implementation manager. If you're an existing client that has already been transitioned as live, you can contact technical support or create your own ticket on the Resource Center to turn this on. Our administrative staff that works with SureScript then will turn it on in the provider master and enable these supported events, which is what triggers the message. Now, these supported events only ensure that the message gets delivered into your inbox. What you can do is give the read permission to anybody in your office who needs to work these messages. Maybe the RX fill, for instance, your front desk needs, because if the patients are calling, hey, did you ever send my prescription to the pharmacy? Can you tell me the status? Maybe they call you instead of the pharmacy. Then you can simply go in there and look at what that drug type is. So even people that are not prescribing drugs need this read permission if they're going to work with these messages at all. So whoever in your practice does user setups can set that role. Now, moving aside from ERX specifically and just looking at general prescription changes, electronic or paper, the diagnosis now supports two, a primary and a secondary. So when you click the multi-select button and it brings up the pop-up of all of your assessment diagnoses, you can choose a maximum of two. The order you select them or click the checkbox is the order they are saved as what is primary, what is secondary. And then that displays on your tooltip and on the prescription template accordingly. Also at the bottom, you'll see that for liquid oral drugs, if you choose a dosage or dispense unit other than milliliter, the system will warn you that it must be milliliter for an oral drug, an oral liquid drug. Medication history. There's a new property that when you do the medication history query, that it only looks at 1 year instead of 2 years. The default has always been a 2-year search, but now if you wanted to only search for 1 year, you can. Also, the contents of the pop-up has been modified. One, the patient name as coming back to us from SureScript is called patient received there on the left, compared to patient in EMR. So you can see sometimes there's misspellings. If there's anything wrong, you'll be able to decide if you want to update the demographics or not. Also, if we do a query and we do not find benefits for the patient, it's going to correctly say patient not currently a member of health plan now instead of patient not found, which it used to do before. So patient not found will truly mean demographics are wrong and we can't verify the patient at all. But patient not member of health plan means we found them, so your demographics are right, but there's just no medication history for the patient. And now all of these changes that we just talked about are also tied to current medications, of course, because everything you do on the prescription screen automatically goes to current med. So on current medications now from your face sheet, there's a brand new column called SureScript Status, which has this new pill bottle icon. When you hover over the icon, it will give you a tooltip, which is the type of message and was it approved or denied. If you click the icon and you have the rights that we just mentioned, it is going to open the actual document from the document list. So instead of having to toggle the document list first and look for it, you can just click the icon and it'll open the message up. That is also embedded into history. So there's a new column called SureScript Status under current medication history, which also records these messages. So it's a complete workflow. Now, looking at other system-level changes and features for the certified version, there is a new automatically interface social, psychosocial, behavioral data template under social history. Now, you do not need to start using this unless you want, but it is going to be automatically given to you in your database. It has all of these predefined systems and elements. Now, you may already be asking some of these elements in your existing social history, which is why I say you do not need to start using this unless you want. Most people are already asking about depression, stress, alcohol, etc. The significance of this change, however, is that you can associate an LOINC code not only to the question, but to the answer and or the specific result within the answer. Previously, the LOINC code was only a requirement at the question level. Now it is a requirement at the answer level as well. Now, again, in the tangible world, SNOMED codes, LOINC codes, have not widely been implemented by the insurances and by Medicare. Certification is requiring it, and therefore they're probably anticipating, as is common sense, that eventually the insurances are probably going to require this too. So we're getting the structure in place. You can start using it if you want. It's a requirement of certification, not mandatory for compliance yet. So use that for what it's worth. Similarly, under family history, there's now a SNOMED option for the problem. It was only for the relationship. Now it is both relationship and problem. So there are two SNOMED searches now under family history, regardless of if you're doing it by relationship then problem or problem then relationship. And when you click the icon, it will open up the standard IMO diagnosis search, but it will be pre-filtered to diagnoses that say family history. If you then want to choose a regular diagnosis other than a family history of, you can click the clear link, and then that will become your standard diagnosis search, and you can search for any ICD you want. And whenever you're searching through the family history, then you will see the problem SNOMED as well as relationship SNOMED. Allergies has a new column called adverse event type. Also, the reaction is now a search field with a binocular master file search instead of free text. Reason again is reactions now have SNOMED codes. The adverse event type is if you are importing a CCD for a transition of care. This is a value now in the new CCD format called adverse event type. So we had to have a field to accommodate that. So if you're not using a CCD, you can manually use it or not use it. It's not mandatory, but it will be used if you're importing a CCD. So that is what the new field is about. And then similarly, under past medical history, there's a new field called problem control. Again, you can use it manually if you so desire, but it's there because CCDs will now be transmitting that field. Vaccinations, some changes here, primarily if you do immunizations and are part of a vaccination registry interface because of meaningful use, and now because of Quality Payment Program MIPS, for which it is a requirement. A lot of changes are now applicable because of vaccination registries. For instance, in addition to mother's maiden name, there is now multiple birth indicator and sequence in name. Now, these aren't mandatory, and especially if you're not doing an immunization registry interface, if you just issue a flu shot or something, you don't need to worry about it manually. It's not forcing you to enter the data. But if you are doing an interface and it is required for your interface, then you will need to enter this data. If you go to administer a vaccine, there's now a new drop-down called funding source with predefined values. Again, that is relevant for the registry. This is only when you're choosing the option vaccination on this visit. If you're just indicating history and you did not actually do it, then that will not be a requirement. Because of the presence of registry now and it being a mandatory requirement, both for Medicare and Medicaid providers, CVX code is now mandatory for all of your vaccines in the Vaccine Master. Also, based on this new property you see at the bottom, the registry interface is now bidirectional available for you. And if that is the case, then you will have these new buttons turned on, registry and response log. That has to do with the bidirectionality now available, which would have to be turned on by our people, as well as with your registry. Now, when you try to administer a vaccine without a vaccine CVX code, you will get an error telling you it's mandatory. So under your master file, that is where the CVX code is attached. Now, many of you may already have these in there, especially if you're using a registry, it's already in place, so you don't need to worry about it. But if you're not already using it, then you will have to now. So we're giving you the link there to the CDC website where the vaccination list has applicable CVX codes. So you can go to that link and update your master file accordingly for the vaccines you use. Also, based on that CVX code, the VIS, if you distribute that to your patients, if there's multiples, you can now choose which one you want. Also, at the vaccine master level, if you are creating a new manufacturer or a new lot number, you will now need to include NDC and brand. Those are mandatory. Next item, patient education, specifically the Medline Plus education. Now, Medline Plus education is not a new feature. It's been there for a couple years now. It is an automatic web interface that gives you live access to education links from this company called Medline Plus, which is associated with the National Library of Medicine. So it's real-time education from the web based on these different indicators in the blue box. Past medical history or assessment, it's based on your ICD or SNOMED code. Current meds, it's based on the RX norm or the NDC code. Allergy, it's based on SNOMED. Lab result is based on the LOINC code for the laboratory result. So on all of those screens in PrognoCIS, you have an EDU column for education with this little blue book icon. When you click that book now, the language will automatically translate to the patient's preferred language if it is supported by the Medline Plus Corporation. Now, if the language is not identified in your patient register, or if it is a language that Medline Plus doesn't support, then it will still be in English. But as you see here in my example, I'm showing the education in Spanish because for my patient Olivia Pope, I've given her Spanish as a preferred language. Now, again, this is only applicable for the Medline education. Your PrognoCIS education obviously is static, whatever you attached, so it will not get translated in real time like this will. If you build expressions, an EMR expression versus a Medline Plus expression, when you go into the parameter button now, it will be auto-populated with a bibliography as unknown. The bibliography details are now mandatory for certification so that when the user is reading the contents of these pop-ups, they have an option of clicking on the bibliography to see the source. So because it is mandatory, we're giving you the fields, but we're just putting everything in there as unknown because many of you already have your own pop-ups that you've created and you didn't have that information already. So to accommodate certification requirement, we've added these fields automatically with the value unknown. You can go in and modify it if you want to put who the author is and the date of publish and so on, or you can leave it as unknown. That would be your choice. But for the certification requirement, as you see in the blue box, there's now going to be a hyperlink called See Bibliography, so that if you want to verify the source, you would be able to do that. System level auditing has been enhanced to now include when a user exports or downloads something. Now, all those bullet points there at the bottom are where you have the option of exporting or downloading, whether it's a file, a report, a drawing. This is now going to be recorded in the audit trail as to who did it. And then the report itself has been modified for user level activation or inactivation for these different user types so that the audit is clearer who is getting activated, who is getting inactivated, and who's doing what at a user level. So those are the general features in the EMR side. Now, just a couple of features on the patient portal, which of course are associated with EMR. The unknown gender is also available on patient register. So if a patient now wants to self-register and identifies neither as male or female, that person can choose unknown. They can also, however, not identify their personal sexual orientation yet. That is not applicable on the portal. That is only in patient register currently. So for the transgender who wants that identified, they'll still have to do that once they're in the office. The label change for preferred language now is going to display only the preferred. So even though you can accommodate up to 10 languages in patient register, the patient will only see their preferred. And the same with ethnicity and race. Now, one of the new features for certification is that a patient, can now actually send a reference link to the provider using the portal. So, for instance, in the example that I'm using on the next screen, the patient wants to give you access to his other doctor's patient portal. Maybe I'm coming to you as a heart specialist, but I want you to see what my family doctor has done so far by giving you access to my family doctor's patient portal. That way I don't have to print and copy and scan documents so that you can see them. I'm just sending you access to that secured portal link. So that's what this function now allows. It's the same way as attaching a document to the doctor, but as my number 3 shows, you will choose reference link. And then inside that reference link, you will simply type in the URL. Again, in my example, I'm typing in my portal so that you can look at my portal lab reviews. You can type in a note to the doctor. Now, this is the patient again. And then on his document list, it's going to say pending so that the patient knows that he has sent this to you. Now, in PrognoCIS, the patient's doctor is going to get this message, provided the supported event is turned on, approved portal attachment. And then when you click the Zoom icon, you will see as a hyperlink what the patient transmitted to you. So now at this point, you can simply click on that hyperlink, and then that would give you access to what that patient wants you to view, such as my portal lab. At that point, then, you can inform the patient that you accept it or that you deny it. The reason you may deny it, maybe the link is broken and it didn't work. Maybe I gave you the wrong link. So you're just going to let me know I'm unable to view it, I got an access denied error or whatever, and then that will notify the patient on the portal again that you weren't able to view it and the reason why based on what you entered. But if you approve it, it's going to put a link also on your document list in EMR, and then the status for the patient on his document list will also show approved instead of pending. That way, one of the meaningful use requirements of secured messaging, this qualifies for that because it's a communication back and forth. Also on the portal, a new option called Past Health Summary. In addition to that, even though I don't have it mentioned here, my next slide, no. The actual label Health Summary has been changed. It used to be Ambulatory Summary. So it's now updated to current CCD nomenclature of Health Summary. And that one remains the current one only, but now there's also one for accessing their past health summaries. And if the patient chooses now to view or download or print, because that is a requirement of meaningful use, as well as Quality Payment Program MIPS, it is now going to have a modified design change for certification. So the design change wasn't related to meaningful use quality payment, but the patient accessing it is. So this is just to let you know you should inform your patients that do it, if they've done it already, that this screen is totally different now and interactive for the patient. And then if they're going to download it, they have the ability of password protecting it, of course, and sending that file to you. And then when they're going to open it, or send it to a third party rather, the password would need to be required to extract the data. So basically, this is when the patient is generating his own CCD document on the portal for the sake of sharing it with somebody. He also has the option of transmitting it directly from the portal. It requires secured messaging be enabled, however. So that would be set up through our staff, or with you through our staff, to have secured messaging enabled since it's PHI. And then there's an audit trail here of when the patient views, downloads, or transmits it. All right, so that's the extent here of the features within this upgrade. This appendix, again, is just copy and pasted from my other presentation in case you did not attend it or you just want it all in one place. It goes through the scoring that CMS is applying for your quality payment MIPS. So as a final reminder then, with regards to our resource center, There is a recorded version of this webinar. Actually, I'll be updating it with this one because some things have changed here in my PowerPoint. So later today, I hopefully will be able to get this recorded version posted. Under the videos, webinar videos, also under documentation, user guides, you can download the PowerPoint version that you've just been looking at. And then, of course, you're already aware of the webinar schedule tab because you've attended this one today. But we have modified, as of this week, the schedule page to now include a description because we are having so many with titles that seem almost similar. The description is going to let you know specifically if that's the session you want to attend or not. And there will be more videos coming again, or webinars rather, especially towards the end of the year when we get into the reporting and the dashboards. So please remember to keep your eye on that. Okay, so are there any questions from anybody present? You can go ahead and type it in the question box to me, or if you click that little hand icon, I can unmute you to listen. Alrighty then, I'm not seeing any questions, so I want to wish you all a good weekend, and thank you for your attendance today.